I want to talk today about what you can expect if you're having a first visit with home health professional. So typically what will happen is either a nurse or a physical therapist will come and do that first visit, and that is an admission to home health services, and that starts your 60-day period and starts you on services with consent and a full assessment to see if you're appropriate for home health and what members of the team need to be involved. So I'm a physical therapist, so I'll kind of talk more from that perspective. Nursing is usually involved as the first discipline if there's a wound, a catheter, or more of a medication management or new disease that's been diagnosed, and management and education for the patient. So those would be some indications of when a nurse would be the first person coming to see you, and then physical therapist would be the first person coming to see you if it's more of a mobility only or strengthening only or just a therapy only plan of care. So that's the difference in that, who's going to come see you that first visit with home health. So the nature of home health is that we see people who are homebound. Typically, there are a few exceptions, which I talk about in the video from last week about home health versus hospice versus palliative care. And so the physical therapist is going to come out and see you whether you have just been discharged from a hospital or a rehab facility, or maybe just your primary care referred you to home health because for you it'd be difficult to get out to a therapy clinic, so they're bringing therapy into your home. So that's the first part of it, and it is billed differently than outpatient therapy where you go to a clinic or an in-home outpatient service, and so that is different as well. Usually this is under Medicare A, which is kind of your acute care, subacute care, rather than your outpatient care, and so it's a bundled payment. It's not usually, usually there's no copay because things are well covered or because people have been in the hospital or skilled nursing and have already met their deductible and things like that. So usually a lower out-of-pocket cost for people than outpatient therapy. So the first visit is going to be pretty thorough assessment because it is a full body, full vitals and full systems assessment. So there's going to be quite a few questions, which some of them may seem like, why does this person need to know this information? But we're basically doing kind of a full assessment of all your systems, how things are going, what our goals are, and what that plan is going to be. So that includes going over medications, especially for people who have been an inpatient. We want to make sure that what's in the house is matching what's on the paper or what's on the discharge paperwork, and making sure that the patient or caregivers or family members are managing the medications as prescribed, making sure there's not anything in the home that they've started taking again now that they've been discharged, and maybe there's an interaction with a medication they were prescribed while they were an inpatient. So we do a full medication list, a full medication reconciliation, which helps us learn about any adverse risks or interactions between medications, and that gives us some information, and then we can report to the doctor who is managing the home health referral about those things and give further guidance whether a medication needs to be stopped or dose modified or anything like that. Another part of it is a cognitive assessment. It's very brief. There's a few questions that's been added in the last few years. So that's just something where we ask, date, year, time, kind of just looking at general orientation. That helps us know a little bit more about the person's cognition, and then we can make decisions based on maybe they need an OT assessment or a speech therapy assessment for further cognitive testing, if that's a change from their long-term condition or status. Or it also helps us kind of think about ability to retain information and learning and what our goals might look like, whether they need a little bit more caregiver assist to be as independent as possible or not. And then, of course, we're going to look at mobility. I'm a physical therapist. That's what I'm going to do, is check strength, check balance, look at mobility, possibly, having the person get on and off the bed, look at the bathroom setup, see what equipment is in there, how difficult has that been since they've gotten home again, looking at just walking or wheelchair mobility, whatever is appropriate for that patient. Using stairs, typically I don't do that on a first visit because there is so much else that we need to gather information on. But that's another thing, especially if it's important for entering and leaving the home, if that's an absolute necessity. So talking about stair mobility, or seeing if someone is going to make a ramp if that's necessary, things like that. And then another thing I like to do at that first visit is really talk through kind of how home health works, what other providers have been referred to them, or if a need is identified during that first visit, who I'm thinking about adding to their plan of care. Maybe that's that OT because there's some issues with getting dressed or showering, or that further cognitive assessment that I'm hoping that they can benefit from. Maybe it's speech therapy because there's still some swallowing issues, or speech issues, or again, the cognition. There's some differences there on assessment where sometimes I would lean towards OT or speech therapy for that cognitive side of things to be addressed. Maybe it's a social worker. Maybe we do need to add nursing because there was a wound that wasn't noted on the referral, or some other issues have come up and they would benefit from further education or training from a nursing perspective. So those are some of the things I would talk about with my patient and their family as well, just kind of who's on the team, who to expect. Is a physical therapist assistant going to be seeing them for some of their visits? I want to make sure they know that person's name so they can expect a call from them. So there's kind of that warm handoff of care, so they know that I'm going to come back in a few weeks and do a reassessment, but in the meantime, a physical therapist assistant that I work closely with will be seeing them. And then there's the consent portion and deciding on a frequency plan. So is physical therapy going to be once a week, twice a week? Typically it's one of those two, as long as that person is appropriate for an admit, and then adding those other disciplines as necessary, providing them with the packet that we give to every patient. Our admission packet has a lot of information in there about emergency planning, advanced directive. It has the consent form, the discharge notice form. Has a place for the different people on the home health team and their phone numbers and names that we can put in there for direct contact from the family or the patient. So really that first visit, typically 45 minutes to an hour, depending on how things go, sometimes up to an hour and 15 minutes or so. I know everyone has a little bit different workflow. Some people I know put in all the meds during the visit, so that definitely could take a little bit more time. So yeah, that's really what to expect during that first visit if you have a home health physical therapy visit, and why they are asking all these questions. It's a very thorough assessment. Really want to get to know kind of who's involved in that patient's care, what the goals are, what their status was before this recent change that led to the referral, and make sure we're all on the same page for what the goals are and how we're going to move forward with the plan of care.